Today we have Tenzin, who is a fifth-year medical student from Imperial. He did his BSc in neuroscience, and he was also the previous academic officer for AMSA. He'll be giving today's tutorial on how to interpret various blood results.
Fantastic. Thank you so much, Chang. I really appreciate the opportunity. So like Chang mentioned, I'll be going through a couple of common blood tests that you're expected to know at your level, and essentially sort of more focused towards the interpretation of these blood tests. So it's very easy to know what's low and what's high. It's more about what causes that abnormality. So in terms of what we're going to do today, really, we're going to understand the clinical indications for the different blood tests. So why would we be doing the different tests, and why, in what clinical setting would you be required to do a particular test? Be able to interpret the common used blood tests and actually recognize the different types of blood bottles, something that isn't really often taught well at medical school. This whole session should probably last about an hour. I'm sorry if I do run a bit over because there's a lot of stuff to go through, and a lot of the content is quite heavy. So hopefully you may have already gone through some of these tests and interpretation, which will make things easier, but please do bear with me. Okay, so just before I begin, I just wanted to mention that the clinical scenario in which you require a blood test is actually really important. So what I mean by that is, why are you doing this test? Why would you order this test? One thing I notice a lot of medical students do in an OSCE is that when it comes to actually listing out this sort of different investigations that they want to do, they start listing out all the blood tests that you can possibly ask for from the NHS, which is not really practical, and it doesn't really show that you're a good clinician. You actually need to try and understand why you want to do a set test. For instance, if you are concerned about anemia in a patient during a cardiovascular station, you want to explain that. You want to say you want to do a full blood count, and therefore because you're quite concerned about anemia. So it's very important that when you do come to your investigations, do mention and explain why you're doing this test. And it's not just for your OSCE setting, but also in a clinical setting when you end up being a doctor. Obviously, I'm not going to go through how you take blood. All that you go through, you'll learn that in your OSCEs, but essentially you need to also know the different techniques and maintain the aseptic technique. You need to be able to recognize the different equipments that you're using, be able to label your blood test tubes and document it. This is something that's also quite poorly done by medical students, and you will be expected to know how to do so in your OSCE. So do make sure you include the patient's name, date of birth, hospital number. Usually the labeling, you have an automatic printed sticker that you put on the test tube, but it is very important that the blood sample corresponds to the right patient, because you don't want to get that mixed up. And finally, documenting as well, talking about the indication for the blood test and what kind of blood test that you're doing. And finally, you want to interpret the results that you get back on the background of the patient history. So for instance, you might be concerned about how the patient is responding to medications, and based on the blood test that you get, you can see whether the patient is doing well or not. Okay, so that's just a quick sort of background, and we're actually going to now go through a couple of different blood tests. But what I've sort of done with this whole presentation is I've divided it into different sections based on the colored bottles that you get, and the different tests that are associated with it. So the first one, and probably one of the most commonly recognized one, is the purple or the lavender bottle, which contains an anticoagulant called EDTA. And when you do sort of collect blood in this bottle, you want to at least get 1 milliliter of blood, and make sure that you invert it at least 8 times. In terms of the different range of tests that are conducted, the most important is obviously your full blood count. And then you also look at your erythrocyte sedimentation rate, your HbA1c levels, if you want to conduct a blood film as well, you take blood in these bottles. And finally, a lot of other small and more specific tests, such as if you're looking for reticulocytes, you're looking for your red cell folate, your monospot test, or your tacrolimus levels, which is a immunosuppressant drug. The ones highlighted in red are the ones that we're going to be going through in detail. But it's just good to know what sort of different types of blood tests are involved along with the purple bottle. Okay, so your full blood count. The full blood count, probably the most commonly used blood test, looks at three main components. You're looking at your red blood cells, your white blood cells, and your platelets. And in terms of your red blood cells, I mean, you have all these figures, and you sort of roughly have to know them. But what I would recommend everyone to sort of get more familiar with are the first three. You're looking at your hemoglobin concentration, which are different in males and females. It's a bit higher in males. You're looking at your mean cell volume, which is between 80 to 100 femtoliters, and your reticulocyte count. The reason why we're quite concerned about the reticulocyte count is because conditions such as if a patient has hemolytic anemia or bleeding, what happens is that your bone marrow sort of tries to produce more red blood cells to keep up with the loss of blood. And as a result, you get a higher proportion of reticulocyte count. So if your reticulocyte count goes up, you know for sure that there's something going on in terms of your bone marrow producing more reticulocytes. Reticulocytes are immature red blood cells, or immature blood cells. And the other stuff that you might want to look at, but you shouldn't really be too familiar with the rest at your level. So red cell count and your hematocrit, your mean corpuscular hemoglobin, and your red blood cell distribution. These are just essentially, the red cell count is essentially looking at your concentration of blood cells in blood. Your hematocrit is the volume of the red blood cells as a proportion of blood. And then the rest are just more specific. So the amount of hemoglobin in the cell is your mean corpuscular hemoglobin, and your red blood cell distribution, which is the range of sizes of the different red blood cells. Okay, so as I mentioned, the first three are the most important, and we're going to try and interpret different things based on these results. So anemia, probably one of the most recognizable conditions from the full blood count would be anemia. So that is a reduction in hemoglobin, and the patient typically presents feeling breathless and fatigued. According to a blood test, the definition of anemia would be a reduced hemoglobin concentration, less than 130 in males and less than 115 in females. And in terms of how we classify anemia, we classify it based on the mean cell volume, so the size of the red blood cells that we get. And so we technically we classify it into three major forms of anemia. So you have your microcytic anemia. This is where your mean cell volume is less than 80 femtoliters. And the more common causes of microcytic anemia includes iron deficiency, thalassemia, sideroblastic anemia, and lead poisoning. But most commonly, your iron deficiency anemia is a common cause of microcytic anemia. Secondly, your normocytic anemia is where your mean cell volume is between 80 to 100. So the red blood cells actually, they're a normal size. You just have or less hemoglobin concentration in the blood. And something that can cause a normocytic anemia is stuff like acute blood loss, hemolytic anemia, and sickle cell disease. Finally, you have your macrocytic anemia, and that is where you have reduced hemoglobin, but the red blood cells are a lot larger than normal, so your mean cell volume is more than 100 femtoliters. And generally, we classify it into two major forms: megaloblastic macrocytic anemia, which is essentially where you get the production of immature, large red blood cells, and non-megaloblastic. These are more matured. They're still large red blood cells, but these are a bit more matured red blood cells. And in terms of what causes megaloblastic anemia, the most common causes are B12 deficiency and folate deficiency. And for your non-megaloblastic diseases, liver disease, pregnancy, chronic alcoholism, and reticulocytosis can lead to an increase in the mean cell volume by a reduction in hemoglobin. And there are some conditions that generally sort of overlap between two or more. So for instance, sorry, one or more. So for instance, the anemia of chronic disease, essentially what that means is a lot of patients coming in with chronic diseases can present with anemia, and generally they can be either microcytic or normocytic. And this is actually probably the most common cause of anemia in hospitalized patients. And in terms of hyperthyroidism and bone marrow failure, it can also present with a normocytic anemia, or it can present with a macrocytic anemia. Okay. Responds to your intracellular storage of iron. So essentially, if you have reduction in iron levels, you get a reduction in ferritin. You have to be careful though when you interpret ferritin, because it's an acute phase protein, which means that when you have an infection or an inflammation, your ferritin levels can go up. So ferritin isn't the most accurate form of accurate measure of understanding the iron levels. Something that's actually used instead is the transferrin, which is an iron binding protein and transports iron around the body. And it has an inverse relation in the sense that when your iron levels go down, the amount of protein that is available increases. Whereas if your iron level increases, then obviously more binds to the transferrin protein, and so your overall transferrin levels go down. Something that's also included in a hematinics is your B12. So if you remember from earlier, B12 can cause a macrocytic or megaloblastic macrocytic anemia. And that could usually be due to something like, well, more commonly, something called pernicious anemia, which is an autoimmune condition in which you have antibodies that are against the intrinsic factor and parietal cells. And the reason why intrinsic factor is important is because it's actually important in the absorption of B12. So if you have antibodies that attack that, you can't necessarily absorb B12 properly. Other causes of B12 deficiency include malabsorption. So again, something like celiac or Crohn's, or if you had a surgery removing part of the bowel, then you will get a B12 deficiency. And finally, poor intake as well. Again, folate is another thing that can cause a deficiency in folate, can cause a megaloblastic anemia. And this generally occurs due to malabsorption, pregnancy, again, poor intake, and certain drugs as well. If you notice in all of these sort of components of the hematinics, so iron, your B12 and folate, pregnancy seems to be quite a common denominator in terms of its deficiency. So something that you come to find out later on is that pregnant women are generally given something called a pregnant care, where they are given more like supplements in iron, B12 and folate to ensure that they maintain the appropriate iron levels, because these tend to go down during pregnancy because of the increased demand for these vitamins and minerals. Okay, so we talked about anemia. Anemia is when your hemoglobin concentration goes down. So now we're going to move on to polycythemia, which is where the opposite happens. You get an increase in your hemoglobin concentration. And generally, we classify into two major forms, your relative, and this is where you get a decrease in your plasma volume. So if you're dehydrated, for instance, if you have less fluid volume, then the concentration of hemoglobin in your blood will go up. And stuff that can cause that could be an acute form of dehydration, obesity, smoking, having too much alcohol can all cause dehydration. And the second sort of classification of polycythemia is your absolute polycythemia. In this particular case, you get an increase in the red blood cell mass. And in terms of your absolute, it can either be a primary cause, so polycythemia rubra vera, which is a primary myeloproliferative disorder. in which you get, essentially it's a cancer where you get an overproduction of red blood cells, white cells, platelets, but you have a normal or a low erythropoietin level. Erythropoietin is a hormone that is produced by your kidneys in response to low oxygen levels. And what it does, it sort of tries to increase your red blood cell production. So if we now go into your secondary causes, essentially that is where you get increased erythropoietin, so your EPO. And that can happen either as a result of renal cell carcinoma, so it's sort of cancer of the kidneys that leads to increased production erythropoietin, and chronic hypoxia, so low levels of oxygen can stimulate the production of EPO to increase red blood cell production. And this is a normal physiological response, and not necessarily it doesn't necessarily have to be as a result of pathology. So if you, for instance, altitude, if you go further higher up in a higher elevation, then your EPO increases to sort of counteract the hypoxia. Yeah, so just remember that the two main forms, relative and absolute, and on the absolute you have your primary and secondary causes. Forgot to mention, polycythemia rubra vera is often associated with a mutation in a gene called JAK2, which is actually seen in quite a few other myeloproliferative disorders. And that's something that's often used in SBA questions as a buzzword, so do note that. Okay, so we talked about red blood cells. The next component of the full blood count looks at your white blood cells. And I'm sorry that this looks quite complicated. Essentially, what you'd start looking at is your white cell count itself, which isn't very specific. A high white cell count normally indicates an infection, inflammation, or malignancy. And a low white cell count generally indicates that someone's on a chemotherapeutic treatment, immunosuppressive drugs. If there's bone marrow failure, can also cause a decrease in your white cell count, and certain viral infections like HIV can decrease your white cell count. But essentially, the whole point of the white cell count is to give you an idea whether it's raised or decreased, and you get a breakdown of the different white cell blood types to give you more specific information. And this is something that you sort of look at in more detail if you see an abnormality in your white cell count. So neutrophils. A high neutrophil count is generally associated with a bacterial infection. Other things like malignancy, general inflammation, the use of steroids or stress, such as trauma or surgery, can also cause an increase in the neutrophil. But when you see a high neutrophil count, think bacterial infection. And a low neutrophil count, you want to think about chemotherapy, as well as certain drugs. I summarized it here as the 4 C's that you need to absolutely be aware of. Clozapine, colchicine, carbimazole, and carbamazepine are associated with a low neutrophil count. Some of the stuff that could cause a low neutrophil count are viral infections, so EBV or mononucleosis can cause a low neutrophil count, and other inflammatory conditions such as rheumatoid arthritis and Sjogren's. And obviously you have your bone marrow failure. Essentially, bone marrow failure can affect all white blood cell types, because you're not necessarily producing essentially your blood cell production is impaired. The next on the line, so your lymphocytes is more associated. If you see a raised lymphocyte, you're thinking more of a viral infection or more chronic infections. So you know, lymphocytes sort of come into the stage much later on. The neutrophils usually are there first to deal with an infection, and then the lymphocytes come in to sort of finish it off. So generally, chronic inflammatory or chronic infections are associated with a high lymphocyte count. Another thing that you can see is the chronic lymphocytic leukemia or lymphomas can also cause a rise in your lymphocytes. Now, viral infection can cause a high lymphocyte count, but it can also cause a low lymphocyte count, as seen in HIV. So it can go both ways. And then obviously you want to think about all the others like chemotherapy, bone marrow failure, again, rheumatoid, SLE, so other inflammatory conditions. Monocytes, there's not a lot you can get from monocytes, because not very specific to anything. But if there is a rise, think about bacterial infection and autoimmune diseases. Generally, a low monocyte count can be seen in acute infections or steroids. Eosinophils, this is another important thing you need to recognize, that a rise in eosinophils is often associated with three main things. It's either an allergy, there's a parasitic infection going on, or there's an adverse drug reaction going on. We're not too concerned about low eosinophil counts. And finally, basophils, again, quite non-specific, but can indicate some leukemias and lymphomas, as well as other inflammatory disorders as well. So the take-home message is, do try and remember some of the more common causes of a rise in certain white blood cell types, particularly neutrophils, lymphocytes, and eosinophils. Generally, in terms of low white blood cell count, they tend to be quite similar. Chemotherapy, immunosuppressive drugs, and bone marrow failure are the more common ones. Finally, we'll look at your platelets. So the normal platelet count goes from 150 to 450. And we're thinking if there is a decrease in your platelet count, so less than 150, called thrombocytopenia. And what you need to think about here essentially is there's either a decreased production in your platelets, or there is an increased consumption or destruction of platelets. In terms of decreased production, that is very similar to what we saw earlier. So it's such as bone marrow failure or chemotherapy can sort of reduce the production of the normal production of platelets, and therefore you get a low platelet count. Aplastic anemia essentially is, again, one that can cause a low platelet count. So you don't get, it's anemia as a result. Essentially it's bone marrow failure. And then you want to also think about your increased consumption or the destruction of platelets. And I categorize it here as looking at immune and non-immune causes. I know it's quite a mouthful to take here. So essentially what I want you to take home from the non-immune causes, such as disseminated intravascular coagulation, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. Essentially, all these three diseases, all I want you to take from that is that they are diseases in which you get the formation of multiple clots around the body, and as a result, they use up the platelets, and therefore you get a low platelet count afterwards. So they consume the platelets because there's so much clot formation going around. And then obviously you have your immune causes as well. So think about immune thrombocytopenic purpura, which is where you get antibodies that target the antigens on the platelets, and then other secondary immune causes such as immunosuppressive drugs, SLE, you get antibodies again that target platelets, CLL, and HIV infections. HIV can infect the bone marrow and reduce production of platelets, and essentially they can cause a myelosuppression. With thrombocytopenia, you are concerned about increased risk of bleeding. You have low platelet count, so you are in increased risk of bleeding. And the second thing we want to consider when it comes to platelet counts, the opposite end of the spectrum is the thrombocythemia, where you get an increase in the production of platelets above the normal range. When you think about thrombocythemia, you're thinking mainly the primary causes, so myeloproliferative disorders like polycythemia, essential thrombocythemia, which is basically cancers where you get overproduction of myeloid cells, in particular here platelets. And then you want to also think about secondary causes such as splenectomy, chronic bleeding, infection, inflammation, malignancy. A splenectomy, what happens when you remove the spleen, you are essentially removing the ability to remove and destroy platelets. So the spleen is where the platelets sort of go to die, and by removing the spleen, you're impairing that process. So you get a buildup of platelets in your blood, and stuff like chronic bleeding, chronic infections, inflammations. You are essentially trying to force the body towards producing more platelets to deal with the infection or the inflammation and the malignancy. And the thing you're worried about with thrombocythemia is the increased risk of clotting. So there's an increased risk of thrombosis. Okay, so that is our full blood count. Another couple of small tests that we're going to talk about as part of the purple blood tube is the erythrocyte sedimentation rate, which is quite a very non-specific measure of information. And normally you can't really take it by itself. You have to have other tests as well. There's your reference ranges. Essentially, what you would see in an increased, what an increased ESR would indicate is stuff like infection, inflammation, autoimmune diseases, malignancies, and pregnancy, and kidney failure as well. If you have quite a sudden increase in your ESR level, definitely above 100, then you're thinking more along the lines of infection. Something that could cause a decrease in your ESR is stuff like polycythemia, sickle cell anemia, and hyperviscosity. Usually, we're more concerned about an increase in the ESR levels, but definitely when you are thinking decrease ESR, these are certain things that you want to be worried about as well. Generally, what we normally use the ESR for is more about monitoring the overall status of the patient, and it's quite good for, like, if you're monitoring the disease activity or whether they're responding to therapy quite well. Although not necessarily the gold standard test, it is part of a diagnostic criteria as well to have a very high ESR in certain autoimmune conditions like temporal arteritis, polymyalgia rheumatica, and the Kawasaki disease. So if you do see a prolonged, sustained ESR for over a period of a couple of weeks, months, then you might be concerned about these inflammatory conditions, which then requires you to sort of look into more specific tests. And finally, I've included the HbA1c as well. So HbA1c measures the amount of glycated hemoglobin you have. And so it gives you an average, it gives you a picture of the average blood sugar over a period of weeks and months. And essentially it's quite good, unlike taking your blood glucose levels. It gives you this average picture and shows you how well you've been controlling your blood sugar levels over a period of 3 months. Some of the values that you should actually know by heart is what normal and abnormal levels indicate. So normal levels generally less than 42 millimoles. If you're between 42 and 47, you're this is a patient who is in the pre-diabetic stage. And diabetes is classified as more than 48 millimoles or more. 48 millimoles or more. And yeah, so essentially diabetic people, you want to try and have a target that is either 48 or less. But for people who are at risk of being hypoglycemic and are diabetic, then you want to go for a target of 53 millimoles per mole. I just included here as well that you although it's not part of the purple blood bottle, you might also do together. So you might also check your glucose and lactate levels, which comes as part of the gray bottle. And this is where you check for your fasting glucose and your glucose tolerance test. Okay, so we've finished with the purple blood bottle. We're going to move to the next sort of another very important one, the yellow bottle, which is essentially done for a range of biochemical, endocrinological, oncology, or toxicology blood tests. And the special property about this is that it sort of has a serum separating tube and allows you to separate the blood from the electrolytes and other compounds. You need at least 1 milliliter of blood, and it has to be inserted 5 times. In terms of the different tests that you can perform with the yellow blood bottle, you are looking at urea electrolytes, your C-reactive protein, your liver function test, looking at your bone profile, thyroid function, iron studies. Honestly, there's tons of tests that you can perform with the yellow blood tube. Other stuff, they look at oncology as well, so your tumor markers, which we'll be going through later. They can also look at your cortisol, your sex hormone levels, um, toxicology, the drug levels. So if you also want to monitor your response to drug treatment, then you think about taking a blood sample in this bottle. Your microbiology and also immunology, so checking for your rheumatoid factors and anti-nuclear antibodies and all that usually comes under this blood bottle as well. The stuff that's highlighted, we'll go through the stuff that's highlighted in red, which are probably the more common blood tests that are carried out. So your urea and electrolytes, essentially what you're looking at here is your sodium, your potassium, your calcium, urea, and creatinine. I'm going to be going through sodium, potassium, urea, and creatinine. Unfortunately, I don't think I have enough time to go through calcium, so I've left that out. But what we're going to look at is what happens when there is an abnormality in the osmolality of these compounds. Okay, so first one, sodium. Sodium is actually the main extracellular cation. So if you're thinking about what controls sodium levels in blood, it is the extracellular water, which is actually controlled by the antidiuretic hormone. This is released by the pituitary, the posterior pituitary, in response to reduced blood pressure and increased osmolarity. And what it does is sort of acts on the distal part of the kidneys and reabsorbs water. So when you are thinking sodium, think about ADH. ADH is the main determinant of sodium concentration in your blood. So hyponatremia is having a sodium concentration less than 135. And that is almost always caused by an increase in your ADH hormone, so an increase in your extracellular water content. And the way we classify hyponatremia is based on the volume status. So, and this is essentially looking at the extracellular fluid volume. So there are three main classifications. Your hypovolemia, that is where you have a hypovolemic hyponatremia. That's where you have a low sodium and a low extracellular volume, fluid volume. A euvolemia is where you have a normal extracellular fluid volume, and a hypervolemia is where you have more than normal extra fluid volume. So in terms of the sort of different causes of each kind of hyponatremia, in terms of a hypovolemic hyponatremia, stuff that you're worried about are loss of sodium through diarrhea, vomiting, or diuretics. So you're losing the sodium, the water follows the sodium, and essentially you get low sodium, and you've lost the water as well, so you're hypovolemic. And what happens is that your body tries to restore the balance by increasing ADH and reabsorbing more water from the kidneys. And therefore you end up becoming hyponatremic, but you are still hypovolemic because the amount of water that you absorb from the kidneys isn't enough to sort of balance whatever you lost initially. So hypovolemia is quite easy to explain. I'm going to skip euvolemia right now. I'm going to come back to it. I'm going to go on to hypervolemia, which is typically caused by conditions like cardiac failure, cirrhosis, and nephrotic syndrome. And what happens is you get this increase in your extracellular fluid volume. You get this huge amounts of ADH release, huge amounts of water reabsorption, and your extracellular fluid volume is actually more than what you had before, and that decreases the concentration of sodium. So that's your hypervolemic hyponatremia. Finally, euvolemia is one that sort of confuses a lot of medical students, and quite frankly, I was confused for a very long time as to how to sort of interpret euvolemic patients. But essentially, what happens in euvolemia is that you get certain conditions such as syndrome of inappropriate ADH or hypothyroidism, where you get an increased production of your antidiuretic hormone. So what that does is increases your water reabsorption in the kidneys, and that decreases your sodium levels. Now you might think, okay, surely that increases the extracellular fluid volume, which it does. But what happens is that your body tries to compensate it by trying to excrete sodium to your kidneys, and once sodium gets excreted, water follows. So essentially what happens is that you return, you don't actually, your extracellular fluid volume doesn't actually change, but your sodium levels have gone down, so you are hyponatremic. I know that sort of, it is quite hard to sort of understand that, but I'll actually go through it once more. So for hypothyroidism and SIADH, you get increase in ADH production. And because you get an increase in ADH production, you have more water reabsorption in the kidneys. Now that increases your ECF. But because your body tries to sort of compensate that, it excretes sodium in the kidneys. Because it excretes sodium, your water follows as well, and your volume status goes back to being euvolemic. Adrenal insufficiency, so Addison's disease, generally as a result of a reduction in the production of aldosterone, you just get low sodium reabsorption. And because you get low sodium reabsorption, you become hyponatremic. But you maintain your euvolemia, so you have the normal ECF. So we're going to go on the opposite end of the spectrum, your hypernatremia. And here where it's sort of you need to think more about a decrease in your extracellular water. And I like to broadly categorize it into two main things. So you either have an increase in sodium intake, you're eating too much sodium, so eating too much salt. High medical intake, so being on saline, for instance. Think about Conn's syndrome as well. So too much aldosterone causes increase in sodium reabsorption. Cushing's, too much cortisol. Cortisol also has a very similar effect on mineralocorticoid receptors, therefore increasing sodium reabsorption. And renal artery stenosis, which increases renin, which then increases aldosterone and again sodium reabsorption. So you get increased sodium, and that's quite self-explanatory. It increases the sodium concentration in blood. And then next, we want to also think about loss of water. So losing in the kidneys. So for instance, diabetes insipidus, which is almost the opposite of ADH, and osmotic diuresis, which you see in diabetic patients, essentially where they pee lots and they lose a lot of water as a result, therefore increasing the sodium concentration in the blood. Again, GI losses, so vomiting and diarrhea and sweating as well. You are losing water. I know it might seem a bit confusing because GI loss can be associated with a low sodium as well, but in certain cases where you get that, you get dehydrated, and as a result, your sodium concentration in your blood also increases. And obviously, not drinking enough water as well can increase the sodium concentration in your blood. Okay, so we're done with sodium. Potassium. Potassium is actually the main intracellular cation, and so not the same. So the different processes affect its concentration in the blood, and less so the extracellular fluid. It's more about what determines its absorption in the kidneys and what determines its concentration inside and outside the cells. Hypokalemia is having a potassium concentration less than 3.5. In terms of what could cause a hypokalemia, we're thinking about GI losses. So vomiting and diarrhea, you're losing your potassium through that. Renal losses, so Cushing's and Conn's. Again, we sort of mentioned Cushing's and Conn's, you get high aldosterone. High aldosterone, yes, it absorbs sodium, but what it does to potassium, it does the opposite. It sort of trashes potassium. It gets rid of potassium from the body. So Cushing's and Conn's, high aldosterone increases the sodium reabsorption and increases sodium excretion. And obviously osmotic diuresis as well, where you get where you go to the toilet more, you pee more, and you're excreting the sodium through that. Redistribution into cells. So remember we talked about this, the force that's balancing the concentration of potassium inside and outside the cell. So compounds like beta agonists, insulin, and alkalosis, what they do is they drive potassium into the cell. Alkalosis in particular, what happens is that potassium goes into the cell, and hydrogen ions inside the cells come out to sort of balance the alkalosis. So these are things that can cause hypokalemia. Hyperkalemia is when you have potassium concentration more than 5.3. And the things that could cause it is obviously renal impairment. If you have a renal problem, you can't excrete your potassium, so you get increase in potassium in your blood. Certain drugs like ACE inhibitors, ARBs, and spironolactone all increase potassium. Addison's disease, and the opposite of COMS, you get a low aldosterone level. Low aldosterone means low sodium reabsorption. Low sodium reabsorption, but more potassium in your blood. And finally, release from cells. So rhabdomyolysis, so breakdown of cells or breakdown of muscle can release the potassium that is stored inside these cells, and that increases its concentration in the blood. Okay, so the next thing we're going to look at is your urea, creatinine, and the EGFR, the glomerular filtration rate. So urea, generally your ammonia is converted to your urea in the liver. Ammonia is a sort of waste product of the breakdown of amino acids, and is converted into urea in the liver and is excreted by the kidneys. Urea is quite non-specific, doesn't necessarily indicate kidney injury, but an increase in urea is associated with kidney injury, dehydration, a GI bleed, or there's an increase in protein intake or protein breakdown. And you're thinking that so these are different causes of an increased urea. A decreased urea is often associated with stuff like liver disease, pregnancy, and malnutrition. Creatinine is a waste product of muscle metabolism, and is excreted by the kidneys. And the thing about creatinine is it's actually a lot more specific than urea when it comes to suggesting kidney disease, kidney failure. So raised creatinine is almost always suggestive of kidney failure. If you have too much creatinine in the blood, think about kidney failure. And a reduced creatinine, because like I mentioned before, because it's associated with muscle mass, the less muscle that you have, the less creatine you're going to have in your system. So stuff like rhabdomyolysis, decreased muscle mass, can reduce your creatinine levels. Your estimated glomerular filtration rate is often based on the creatinine clearance, and it is the volume of fluid that is filtered by the kidneys per unit time. And the normal EGFR is usually above 60, often used to categorize kidney failure into different stages. In terms of kidney failure, we classify it into two main things: acute kidney failure and chronic kidney failure. In acute kidney failure, obviously your urea and creatinine are both raised, and you want to break it down into pre-renal causes. So having hypovolemia, sepsis, or vascular problems can result in acute kidney failure. Intrinsic problems, so these are problems associated with the kidneys themselves, so diseases like glomerulonephritis, acute interstitial nephritis, and acute tubular necrosis can all sort of affect the function of the kidneys. And post-renal, so these are mainly your kidney stones that you're worried about. So all of that can cause an acute kidney failure and therefore increase your urea and creatinine concentrations. Chronic kidney failure, when you think chronic kidney failure, that is having an EGFR of less than 60 for more than 3 months. That's the sort of the diagnostic criteria. And when you are thinking about it, please do think about two main things: diabetes and chronic hypertension. Diabetes and chronic hypertension, I think, are huge, two big risk factors for chronic renal failure. I think diabetes is like 2/3 of the risk, and chronic hypertension is like 1/3. And obviously you have other causes of chronic renal failure like polycystic kidney disease or long-standing intrinsic sort of long-standing glomerulonephritis, or any of those kidney diseases can also result in chronic renal failure as well. When you do have an estimated glomerular filtration rate that's less than 15, which is classified as end-stage renal failure, you need dialysis or a renal transplant. So in both acute and chronic renal failure, think about there's an increase in urea and increase in creatinine. Creatinine is more specific for kidney failure. A lot of things can cause an increase in urea. Okay, C-reactive protein, actually this goes hand in hand with ESR as a marker of inflammation, but it's actually more sensitive and more accurate because it measures the state of inflammation at a particular time, whereas ESR sort of takes stays a certain level for a while. So it increases slowly and decreases slowly, whereas C-reactive protein increases quickly and decreases quickly, being more reflective of the state of the body. In terms of what it actually is, it's an acute phase protein that's actually synthesized in the liver and binds to phosphocholine compounds that are expressed on dying cells and bacteria. And what that does is essentially activates the complement system and increases phagocytosis. We mainly use it. Raised CRP is often indicated in bacterial infection. If it's more than 100, it's almost, and in an acute setting, it's almost always a severe bacterial infection. Certain autoimmune conditions as well, like with the ESR, can cause a raised CRP. Pericarditis, cancer, pregnancy, burns, again. We also use CRP to measure or predict the risk of cardiovascular disease as well. But generally, it is a marker of inflammation like ESR, but it's a bit more reflective of the current state of the patient. And as part of your, I think part of the learning objectives, I also had to sort of talk through a few cancer markers as part of your yellow test tube. So I'm just essentially going to go through very quickly. Your prostate-specific antigen, you're looking is sort of not necessarily diagnostic, but can indicate prostate cancer. There's a lot of things that can cause a raised PSA, such as prostatitis, but a very high PSA is indicative of prostate cancer. CA-125 is another cancer marker that sort of is a predictor of ovarian cancer. CA-19-9 is more for like pancreatic cancer or bile duct related cancers. CEA, very non-specific, and actually people don't normally use this, but can a raised CSA is indicative of bowel cancer. But again, a lot of things can actually cause a rise in your CEA levels. CA-15-3 is something they use to diagnose breast cancer. Alpha-fetoprotein, we're looking at primary liver cancers or germ cell tumors. And human chorionic gonadotropin, which is used to diagnose more rarer cancers, so like your rarer germ cell tumors like testicular cancer or certain types of ovarian cancer as well. Essentially, yeah, these are different sort of cancer markers that you might want to look for if you suspect a cancer in a patient. Okay, so we're almost finished now, and we've done with the main two, which is your purple and your yellow. I'm sure if you've been on the ward, you've definitely come across them. I'm going to go through a few sort of more rarer blood bottle types. So your pink bottle is normally done for your ABO blood groups, to categorize your ABO blood groups, and for your cross-matching, and they're generally sent to the transfusion lab. So the main test that you would conduct with this bottle is essentially your group and save, which is grouping the blood group, and then also checking if there are any antibodies, and finally your cross-match, which actually looks at whether there is the donor blood is compatible with the recipient blood. And then you can other smaller tests like direct Coombs test, which detects autoimmune hemolytic anemia. Okay, so yeah, just to recap, in terms of group and save, you're looking, it's a test that's done to look for your ABO blood groups and your rhesus D group testing. So these are the most commonly used blood group categorizations. And then you're also screening for any atypical antibodies in the plasma. In terms of your cross-match, a cross-match can only be done after you have identified the group of the recipient blood and screen for any atypical antibodies. And what you do is essentially mix the patient's blood with the donor's blood and see if there's an immune reaction. If it is safe, then you would issue the blood product. And I just wanted to quickly go through in terms of the different blood groups and what you can receive and can't receive. So the two main blood group classifications, your ABO blood group and your rhesus D group. In terms of your ABO blood group classification, someone with blood group A will have anti-B antibodies. So we'll have group, antibodies that will target group B, sort of group B blood groups. You can't have anti-A, obviously, because if anti-A, they'll start attacking their own red blood cells. So just that's a good way of remembering, I suppose. Think about the different antibodies that are in. So group B will have anti-A antibodies. AB, because they have both A and B blood groups, you won't have any antibodies, because if you do, then obviously you have an autoimmune reaction. And finally, your blood group O, because the blood group O doesn't have any antigens, you get an increase in your anti-A and anti-B antibodies. So blood group O has your anti-A and anti-B antibodies. In terms of the type of bloods that you can receive, for A group can receive A and O. And so you can obviously receive your own kind of blood, and you can receive O blood, because O blood doesn't have any antigens. B group can receive B and O. AB can basically receive everything, and O can only receive O blood. I'm not going to go through plasma. I think we're running out of time. In terms of your rhesus D, essentially the take-home message is that you would never give rhesus D positive blood to a negative. You can give rhesus D negative to a positive, but the take-home message is never give rhesus D positive blood to a negative blood group type. If you are unsure about the blood groups, then you're going to give O negative, because essentially you can give O negative to any person, regardless of their blood group. Finally, looking at the light blue bottle, which is normally done for your coagulation studies. And the main thing that we're going to look at here is your coagulation screen. It also looks at other tests like doing the D-dimer, which measures your risk of thrombosis, your activated partial thromboplastin ratio, anti-10 assay, and other specific clotting factors, or looking for your lupus anticoagulant. In terms of your coagulation screen, you're looking at four main areas, so four main times, or four main specific markers. So your prothrombin time, also known as your international normalized ratio, is the time taken for your blood to clot via the extrinsic pathway. So if you remember your coagulation pathway and your clotting factors that are involved, you have your intrinsic, you have your extrinsic pathway, and you have your common pathway. So I'm not really going to go into too much depth, but essentially your prothrombin time measures how long it takes for your blood to clot via the extrinsic pathway. Because factor 7, you can't normally get an isolated factor 7 deficiency or abnormality. Generally, your prothrombin time is used to measure overall coagulopathy. So if there's an increase, if you have vitamin K deficiency, if you're on warfarin, factor 5 liver disease, or DIC, what happens is your prothrombin time increases because you have a depletion of your coagulation factors in general. A reduction in PT time can suggest something like factor 5 laden or estrogen containing medications, or having actually the opposite of vitamin K deficiency, taking vitamin K supplements. Just wanted to indicate your INR is something that's utilized to monitor patients who are on anticoagulant medications. So your normal INR is usually between 0.9 and 1.3. Less than 0.9 indicates there's a high risk of thrombosis or clot formation. And the NICE recommends certain targets that you must have for INR. So for instance, if you have atrial fibrillation, you're looking for an INR between 2 and 3. If there's a recurrent episodes of venous thromboembolism or mitral valve replacement or lupus anticoagulant syndrome, you're thinking of an INR target 3 to 4. So you want to make the blood more thin, essentially. And obviously, we have a lot more newer anticoagulant drugs, but a lot of people tend to like being on warfarin because they can actually go quite regularly and monitor their INR target and be like, oh, okay, my INR target is actually quite good, and it keeps them quite happy because they know that the medication's working. But obviously, we have more newer anticoagulant drugs available, which don't necessarily require you to monitor your INR regularly. Your activated partial thromboplastin time looks more for the time it takes for the blood to clot via the intrinsic pathway. So these are your factors 8, 9, 11. So the ones that can cause an increase in your APTT are your hemophilia diseases. And obviously, similarly to PT, anything that increases the consumption of your coagulation, your clotting factors will also cause an increase in APTT. And a decrease in APTT similar to a decrease in PT, so factor V laden, estrogen-containing medications, and so on. Okay, so this is your clotting cascade, well, very much simplified. And I just wanted to sort of look into, I'm sorry for running a bit late, guys. I just wanted to look into the intrinsic and your extrinsic pathway. So intrinsic pathway is characterized by the APTT, and your extrinsic pathway is characterized by your PT. Finally, your bleeding time, which generally assesses your overall platelet function. And if your platelets are working well or working too well, that will cause a reduction in bleeding time. If they're not working that well, so things like von Willebrand disease, or as you mentioned, HUC or DAC or thrombocytopenia, so having very little platelets will increase your bleeding time. And finally, you'll also look at your platelet count as well. So this is just a summary of different things that you might see in your coagulation screen, and key things to look out for, like your general coagulation factor diseases which can affect the general clotting cascade, causes an increase in PT and APTT. Hemophilia is more specifically an increase in APTT. Von Willebrand disease associated with a decreased platelet function, which so causes an increase in your bleeding time. Doesn't affect the number of platelets, but it does affect how the platelets function, and also it causes an increase, or it can be normal or APTT. DIC, basically, again, everything is raised, so it's utilizing all the clotting factors, utilizing your platelets, so your platelets go down, and your bleeding times, your APTT and PT all go up. And this is a good way of differentiating it from other stuff like ITP, TTP, and HUS, which cause a decrease in platelets and an increase in bleeding time, but don't necessarily affect your prothrombin time and your APTT. And then just to mention other sort of blood bottles that you might come across are your, but they're a lot rarer, are your red bottles, which do a few more specific biochemistry tests. Your dark green, which they look for insulin or ammonia levels. Light green, honestly, hardly ever used, and it's different between trusts, and sometimes done for specific biochemical tests. Your blood cultures, which you probably will come across. The blue one is for aerobic, and the purple or the red one is for anaerobic bacteria, and it has a medium that allows the bacteria to propagate and to divide. It preserves them. And finally, you have your ABGs as well, which I believe we have a lecture next week that talks about that. So these are just other things that you might come across, but generally the first four are the ones that you will see. Okay, so we're going to go through a couple of SBAs. I didn't make any Mentimeter questions because I think it takes a bit of time, and also there's a limit to the number of questions you can make. So what I'm going to do is I'll give you all a read, let's say about 20 seconds, have a read through and think about the answer in your head. Personally, I don't think typing it helps because everyone else sort of sees the answer, and then you don't necessarily, develop that time to think through things. So yeah, I'll give you 20 seconds to read through this question, and then I'll tell you the answer, and then we'll go through it. Okay, so for this question, quite obviously, patient has presented with anemia. She has a low hemoglobin count. And if you remember from how we classify our anemias, this is a microcytic anemia because the MCV is low. In terms of white cell counts, we're not really worried here. They seem normal. Platelets seem normal. B12 folate seems normal. Ferritin seems normal, so I'm not really concerned about your iron levels, but then again, we want to be quite concerned because ferritin can be associated with inflammation and infection. So I'm looking at my transferrin levels, and that seems normal as well. So in terms of my microcytic anemia, the things that could cause a microcytic anemia are iron deficiency and thalassemia. Acute bleeding, hemolytic anemia, and hereditary erythrocytosis all cause normocytic anemia. Because I don't think there's a problem with the iron here, the answer in this case is thalassemia. Okay, this is your second question. Okay, so the thing to be concerned about here is that this person has a recent travel history and is complaining of abdominal pain, diarrhea. In terms of the blood results, hemoglobin, MCV all seem fine, reticulocytes seem fine, but the white cell count is raised in this case here. When I look at the white cell count breakdown, neutrophils, they seem fine, a bit on the high side, but not something not too worried about. Lymphocytes, fine. Monocytes, fine. Your eosinophils, this is quite an extreme example. You won't necessarily get an eosinophil count of 4, but I just put it here to make it quite obvious. So there's a high eosinophil count. So I am thinking of 3 things: allergic reaction, adverse drug reaction, or a parasitic infection. In terms of the different pathogenic organisms here, I'm sorry if you haven't come across some of them. Salmonella typhi is a bacterium. Hepatitis, obviously the virus. Campylobacter jejuni is a bacterium. E. coli is a bacterium. Taenia saginata is a tapeworm. And so because of the high eosinophil count, I am thinking more parasitic infection. So this is, in this case, is most likely to be Taenia saginata. Okay, third question. Okay, so in terms of this question, we want to know the essentially the blood findings from polycythemia rubra, which is a primary myeloproliferative disorder, and all of them have high HB here. What we're concerned about is in something like polycythemia rubra, you would get a high white cell count and a high platelet count because it's a myeloproliferative disorder and it's producing a lot of these cell types. So we can immediately rule out B and D. In terms of your high white cell count, high platelets, polycythemia rubra generally presents with a normal or low EPO. So we know it's not A. In this particular case, yeah, high platelets, low EPO, and increased plasma volume is definitely worth considering. And final option sort of produces normal EPO, but a reduced plasma volume. So in this particular case, it would be option C. You get a high hemoglobin, high white cell count, high platelets, generally a low or normal EPO, and a normal or increased plasma volume. The reason why it isn't E is this is actually a relative polycythemia because you get a reduction in your plasma volume. And the reason, and number D, obviously you get your high hemoglobin, your normal white cell count, normal platelets, but a high EPO and a normal plasma volume. That is your secondary absolute polycythemia. Okay, so question number 4. Okay, so for this question, patient is fatigued, normally eats well, does not experience any weight changes. Hemoglobin is low, so it's an anemia. The MCV is 130, that's high, so this person has a macrocytic anemia. Immediately that rules out a few differentials, yeah? Everything else seems to be pretty normal and fine, I'm not too worried. So this is a macrocytic anemia. What am I concerned about? What are the causes of macrocytic anemia? Think about your megaloblastic and non-megaloblastic. So megaloblastic, B12 deficiency, folate deficiency, non-megaloblastic, alcohol, liver disease, pregnancy. Yeah. What could be behind the deficiency? So behind the symptoms. So iron deficiency causes a microcytic anemia. Anemia of chronic disease produces a microcytic or a normocytic anemia. Hypothyroidism can present with a macrocytic or a normocytic. Pernicious anemia, which is B12 deficiency, because antibodies are against the intrinsic factor. Intrinsic factor, you need to absorb vitamin B12. So that is very likely a possibility. And sickle cell anemia, which presents with a normocytic anemia. So we rule it out down to two things. So it could either be hypothyroidism or pernicious anemia. Given the patient's history, where she says that she normally eats well and has not experienced any changes in weight, I am more inclined to say that this is a case of pernicious anemia. But you can definitely conduct your thyroid function test to confirm your differentials. Question 5. Okay, so in this one, clearly, patient has a low sodium and a high potassium. Calcium seems to be in the normal range, urea seems to be normal, and creatinine, I'm not too concerned about. CRP is less than 10. So this person has a hyponatremia and a hyperkalemia. Of the different conditions that are listed here in the as a differential or in your multiple choice, syndrome of inappropriate ADH does present with hyponatremia. Cardiac failure presents with hyponatremia. Con syndrome, too much aldosterone, so that presents with a hypernatremia, so we know it's not C. Addison's disease can present with a hyponatremia, and a diarrhea can present with hyponatremia. In terms of the clinical history there, the thing that differentiates between all these things is the potassium. Potassium is high. Potassium wouldn't be high in your syndrome of inappropriate ADH. It wouldn't be high in your cardiac failure. It wouldn't be high in your diarrhea. So the only possible explanation for this is Addison's disease, where you get an increase in the production of your aldosterone. Opposite way. It decreased production of aldosterone, which means that you get less sodium in your blood and more potassium. Question 6. So here, sorry, I'm sort of rushing through some of these questions, but I think as I explain it, you can still work it out. So here, the sodium seems to be more on the lower side, but it seems fine. Again, potassium on the lower side, but seems fine as well. Your calcium is normal. Urea is normal. Creatinine is quite low. It's less than normal range here. The CRP seems to be fine as well. So a reduction in creatinine, what could possibly cause a reduction in creatinine? Well, I know dehydration wouldn't necessarily do that, and also would present with an increase in your urea. Your acute kidney injury, yeah, when you're thinking acute kidney injury, does affect creatinine, but it affects it in the opposite direction. It increases your creatinine and increases your urea. Decreased muscle mass is definitely something that could cause this, because your muscle mass is directly related to your creatinine levels. So a decrease in your muscle mass decreases your creatinine levels. And other stuff like high protein diet and heart failure, not really convinced. High protein diet increases your urea levels. Urea seems fine and doesn't necessarily have to do anything with creatinine. And finally, heart failure. Again, something that you won't necessarily see with this presentation. So the answer for this is your decreased muscle mass. Question 7. I will admit this is a bit hard because I don't think I've gone through the coagulation screen quite thoroughly. So I do apologize. But in terms of this question, what we're really concerned is just to have a look at the ones that are affected. So the only thing that is affected is APTT. So if you remember from the slide before, the only thing that affects your APTT, that is your measure of time or how long the blood takes to clot in intrinsic pathway. So those are your factors 8, 9, and 11. yeah, and the only one that could cause an isolated increase in your APTT without affecting your PT, your bleeding time and your platelets is hemophilia. Von Willebrand disease can present with an increase in bleeding time and possibly an increase in APTT. Warfarin will affect your prothrombin time and APTT. Again, factor V will also affect your prothrombin time and APTT. Finally, disseminated intravascular coagulopathy, so your DIC, is where you get widespread formation of clots around the body. And what essentially that does is utilizes up the platelets, utilizes the clotting factors, and that decreases your level of clotting factors and your platelets. So they go down, platelet count goes down, but your PT, your APTT, and your bleeding time all go up. Question 8. This is quite a straightforward one. Essentially, what I'm looking for is just what is the target INR for someone who is on an anticoagulant, so is on warfarin therapy, following an atrial fibrillation. Normal INR is between 0.9 and 1.3. 1.1 to 2.0 generally not used as a target for anything really. 2.0 to 3.0 is generally used for atrial fibrillation and a few other conditions. 3.0 to 4.0 is for venous thromboembolism that is recurrent despite treatment. Maybe a heart valve replacement can also require an INR of this range. And more than 5, that is a huge increased risk of bleeding. So you want to be careful of someone in that range. So the answer is INR between 2 and 3. Oh, sorry, I gave the answer away. Essentially, for this one, I just want you to recognize what sort of blood products are safe to give to this patient. Patient is B negative, and in terms of a B negative blood, you can definitely receive B blood. You can definitely receive O blood, and you need to also think about your rhesus D classification. If it is a negative, if it is RHD negative, then the only kind of blood that you can receive is negative blood. You can't receive positive blood because there's a risk of a reaction. So this answer in this particular case, it is E. So you're looking at your group O negative blood. Group A negative blood wouldn't be safe. Group O positive blood wouldn't be safe. Well, group O is okay, but because it's positive, you can't give it to a rhesus D negative patient. Group AB negative, not necessarily. Group B positive, yes, you can give group B, but again, it's positive here, so it wouldn't be the safest choice. And finally, your group O negative. Group O negative is your universal blood donor, and it's something that you would give in an emergency setting. So if you do not know the blood group of the patient, you give group O negative. And finally, for the last question here, I just want you to recognize a cancer marker that you might see in this patient. So the main thing here is that there's a past history of breast cancer, heavy smoking, quit about 10 years ago, complained of feeling bloated, so there's abdominal pain. In terms of the presentation of this patient, I'm thinking more along the lines of it could be a possible ovarian cancer. And in terms of what kind of blood tests I might take or tumor markers that I might do to sort of, doesn't necessarily confirm, but to help raise my suspicion, would be your CA-125, which detects ovarian cancer. Something else that you might do is your CA-15-3, which I haven't mentioned here, but that is for detecting the possibility of breast cancer. Given the symptoms of the patient, it's more likely to be ovarian. And the rest, obviously, CEA detects your bowel cancer, alpha-fetoproteins for liver or other germ cell tumors, CA-19-9 for pancreatic tumors or biliary tree-related tumors, and prostate-specific antigen. It's not necessarily specific for prostate cancer, but is quite indicative if there's a very high PSA level. And thank you very much. That finishes my presentation. I'm sorry I overwent on the time. There was a lot to cover, and I'm sorry if I couldn't go into depth with some of them, but hopefully that was great. You understood most of the stuff.